All right, everyone, welcome to Psychopharmacology. My name is Professor Collado. This week, we're going to talk about pharmacokinetics and pharmacodynamics. So I'm going to ask some of you guys what your understanding of it is. We're going to clarify it. Alejandro, I know you're very vocal. You talked a lot last week, which I like, so I'm going to ask you first. All right? So what is your understanding of pharmacokinetics? You're on mute, Alejandro. I can't hear you. I don't think is all right, what about Alyssa?
Isn't pharmacokinetics like how the medication works in the body?
No.
No.
What's the other
What's the
alternative?
Huh?
What's
Sorry,
the
can
other
you repeat?
alternative? It's not what the medicine does to the body, so it's
Is
what
it
the
how the
body
body
does
affects the
with the meds?
medication?
very good. Okay. So if I'm taking a medication and I go to I don't know, the vitamin shop and the guy's like, take this because you're gonna have more gains in the gym, and now my medication stops working. Is that a pharmacodynamic issue or is that a pharmacokinetic interaction? You guys can call it out.
Kinetic.
Pharmacokinetic, right? If I'm taking a medicine for my GERD and now my antipsychotic medication stops working, is that a pharmacokinetic interaction or pharmacodynamic interaction?
Dynamic?
What?
Pharmacodynamic?
No, pharmacokinetic. If I am diagnose someone with psychosis, but I give them a medication, right? And I'm sorry, if I diagnose someone with ADHD and I give them a medication, they become psychotic. Is that pharmacodynamic or pharmacokinetic?
Pharmacodynamic.
Very good, pharmacodynamic, right? Because I'm increasing dopamine, but I should be blocking dopamine. All right. If I give someone an SSRI, but I misdiagnose them with depression, but they have bipolar depression, is that pharmacodynamic or pharmacokinetic?
Dynamic.
Very good. All right. If I start drinking a specific tea and now I'm having side effects of medication, is that pharmacodynamic or pharmacokinetic?
Kinetic.
Pharmacokinetic.
Very good. All right. If I do genetic testing and I take a medication that makes me a poor metabolizer and I take that medication and I start having side effects, is that pharmacokinetic or pharmacodynamic?
Kinetic.
Very good. All right. So anything that interacts the absorption, right? How the body is absorbed through the stomach, small intestine, large intestine, right? Sublingually, distributed. How is it distributed to the body, to the fat cells? How is it metabolized, right? Using the cytochrome P450 enzymes, or how is it excreted is a pharmacokinetic interaction. Does that make sense? Again, so ADME, absorption, distribution, metabolism, and excretion, right? Anything that affects that is a pharmacokinetic interaction, all right? A drug-drug interaction is usually a pharmacokinetic, but it also can be a pharmacodynamic, and I'm going to explain that, for instance, right? If I give someone a medication that's an agonist and antagonist at the same time, that will be pharmacodynamic, right? Because it's what the drug is doing to the body and the mechanisms are interacting with each other. Get it? If I give a drug that's causing the change of metabolism of other medication, then that would be a pharmacokinetic interaction. Does that make sense? Or it could be both. It's not one or the other. Sometimes it could be both also. But I want you guys to understand those concepts, all right? Pharmacokinetic, anything that affects absorption, distribution, metabolism, excretion. Pharmacodynamic, mechanisms of the drug, what it does to the body. And it could be, let's say someone is on a beta blocker and then they have an asthma attack. And now you try to give them albuterol and it doesn't work. Is that a pharmacodynamic or pharmacokinetic interaction?
Pharmacodynamic.
Very good, right? So you're giving someone a beta blocker and a beta agonist, right? Albuterol is a beta agonist, and you need that to breathe, but someone's on propranolol, right? Which is a beta blocker. So both those things are working on the body and it's interacting with you. Does that make sense? Okay. Okay. Tell me about the different systems of how the meds are working in the body. So you have what? You have meds that work in the 12 transmembrane system, right? Which is what? What's an example of that from the Stallbook? 12 transmembrane. They work on
Reuptake.
very good reuptake pumps, all right? What about the 7 transmembrane? What is that? 50 Cent is part of a group, was part of a group called 50 Cent was part of a group called G unit, G coupled receptors, all right? What is ion channel linked? What's the difference with that?
Those are like fast acting.
Okay. They could be. Yep. Ligand or ion channel link. Yep. And what's the other one called? What are anticonvulsants?
Anti-voltage.
Voltage gated?
Voltage gated. Very good. And what's the other one that's only about 10%?
Ligand gated?
Not ligand. We talked about ligand already.
Enzyme.
Enzymes, right? So let me repeat again. You have the 12 transmembrane, which usually works on reuptake pumps, right? Norepinephrine reuptake pump, dopamine reuptake pump, serotonin reuptake pump, all right? You have the 7 transmembrane, which is G protein coupled receptors, right? You have ligand gated or ion gated, same thing, ion channel gated. That's together. You have voltage gated, which is anticonvulsants, right? And then you have the enzymes, which usually there's only 2 we use in psychiatry. What are they? Monoamine oxidase inhibitors, right, which we use for treatment-resistant depression. And what's the other one? Someone is confused and it's progressive. They don't remember anything.
Is it I said it.
Alzheimer's, right? Yep. Acetylcholinesterase inhibitors. All right, so monoamine oxidase inhibitors, acetylcholinesterase inhibitors, those work on enzymes. You have G protein coupled receptors, which are usually some of the serotonin receptors and the antipsychotics, obviously. And you have the 12 transmembrane, which is the reuptake pumps. All right. Any questions about what the differences are? Can someone explain to me what the differences are? What's the difference between a G protein coupled receptor and a ligand gated / ion gated channel? What's the difference? It was I was having a panic attack. Would a medication that works on ligand / ion gated be better for me, or would it be a G protein coupled receptor medication? Which one would be better?
Ligand, because it's faster.
It's faster, right? How long does it usually take for G protein coupled receptor to work using the cascade? How long could it take?
Like 2 weeks at least.
At least, yeah.
More.
Sometimes longer, yeah. All right. So I don't expect you guys to know all the different steps of it, all right? But just have a general understanding, all right? You don't have to know the difference between the phosphates and phosphatase and all that stuff, the kinase. Just have a general understanding of it, but just know that it's going to take a little bit longer to work, all right? And which meds work on that pathway. Does that make sense? All right. Ligand gated would be like a Xanax. You take it on a plane ride, within 20 minutes, you're relaxed, and it'll last for like an hour or two, all right? Which is why we use it for very short bursts. If someone's having stress for, I don't know, I usually don't give it for like exams because you don't want to give a benzo. It makes you like lose focus. But, you know, for flights, very high stress, you know, meeting your in-laws, maybe Xanax would be okay for the first time, all right? Antipsychotics, G protein coupled receptors, that's why you have to take antipsychotics regularly, right? You can't just take Haldol once and your psychosis gets better. It's going to be progressive. And if you do, a lot of times it's going to be the antihistamine properties, right? That sedates the patient. They're still going to be hearing voices. It's going to take time for the auditory hallucinations or positive symptoms to get better. Does that make sense? All right.
What exactly does it mean, like 12 transmembrane or 7? Does that mean it's going in and out across the membrane?
Just the way you classify it. Yeah, it's just the way they classify it, you know. It's not significant in clinical practice, but if you're doing research in like neuroscience, I guess it makes sense. But for us, we just have a general understanding for now. All right. And just know about the conformation changes, you know, for the G protein, when it binds, it changes conformation, right? And the cascade starts. All right. What part of the neuron is where, you know, all this stuff happens, right? All the magic. What part of the neuron? The part that has the nucleus. What is that called?
The soma or cell body?
The soma or cell body. All right. So all that stuff, DNA transcription, translation, all that stuff happens in the cell body. All right. Obviously, you have the axon, which is what? If you look at the axon, what is it responsible for? Is it responsible for the electrical stimulation or is it chemical transmission?
Electrical.
The electrical.
It will be electrical, right? Because you have all the sodium pumps there, right? That are going to open. And at the very end, you're going to have the calcium that goes inside. Once calcium goes inside, it triggers the release of neurotransmitter, all right? Which is why we use anticonvulsants. If someone is manic or having seizures, right, it's hyperfiring. How do you stop that from firing? You affect those channels, right? When you affect sodium channels, you affect calcium channels, and you block the sodium channels, what's going to happen? That action potential is not going to happen, right? So that presynaptic neuron is not going to fire, and therefore it's not going to cause a seizure, or in theory, it's not going to cause a manic episode. Does that make sense? All right, we're going to talk more in detail as we go into the medications, but I'm trying to just give you guys a general understanding of it now, right? CYP enzymes, what are those? Can someone explain that to me? Enrique, can you explain the CYP enzymes to me? What do they do? What are they responsible for? What about you, Misun? Don't be shy. Anyone want to chime in? Yes, Misun, you ready? What do CYP enzymes do? What are they responsible for? Okay, no problem. Okay. Anyone want to help her out? Anyone want to chime in? What do CYP enzymes do?
For metabolizing.
Metabolizing?
Okay.
Drug?
Good. They metabolize the drugs, right? So what happens if the CYP enzymes are not working correctly? What's going to happen? Is it going to be a pharmacodynamic issue or a pharmacokinetic issue?
Pharmacokinetic?
Pharmacokinetic issue, right? So if someone doesn't make enough CYP2D6 and the medication needs CYP2D6 to be broken down, what is going to happen when you give them a medicine that relies on 2D6 for it to work? Are they going to have side effects? Are they going to have no effect on the drug? What's going to happen?
Side effect.
Side effects?
Because if I do a drug level, what's going to be? Is it going to be high or is it going to be low?
High.
Hi.
High, right? Because you don't have the CYP2D6 to break it down. All right. So if I give them an inhibitor of CYP2D6, what about if I give them an inducer? What's going to happen? Will the drug level drop or will the drug level rise?
It would drop low.
Very good. Will they be prone to side effects or not?
No.
Not
side
prone.
No. All right. And the medication is probably not going to work. Right. What about a drug that,
I have a question.
yes.
Like other drugs that they need to be metabolized to increase their potency, or they always go down after metabolized?
No, it depends. There's drugs that are prodrugs that need to be converted, right? Like tamoxifen for breast cancer, right? Or codeine has to be changed to morphine, right? Some drugs are prodrugs, so they have to be metabolized, not to be excreted, but metabolized to be activated. All right, so you need to understand, is it a prodrug? If it's a prodrug, then it needs to be metabolized. So then it would be the opposite, which can be confusing sometimes. So if you give someone an inducer, there's going to be more effect of the medication because more of the active drug is going to be created, right? For instance, if you give someone an inhibitor, nothing's going to be converted to an active drug, so therefore the med is not going to work. Does that make sense? If it's a regular drug, then it will be the opposite. So you have to really understand these concepts for you to put it together, all right? There's like 3 steps. There's 3 steps if it's a prodrug. There's 2 steps if it's a regular drug metabolism. Does that make sense? Okay. What are some of the CYP enzymes that we need to know in psychiatry?
3A4?
3A4 is one. Okay, excellent. I said 2D6. What's another one? Two C9.
1A2.
1A2, very important. That's another. What's another one? 2C19. All right.
3A4?
3A4. Okay, so there's like 5 or 6 that I want you guys to know. 3A4, right? The most common one in all of medicine. 60% of the drugs are metabolized through 3A4. All right. 2D6 is insignificant because a lot of our psychiatric meds are 2D6. But you should know 3A4 because if you treat older clients, they're going to have a lot of meds that are medical, like statins, they're going to be 3A4. All right. 2D6, beta blockers, atypical antipsychotics. All right. Atomoxetine for ADHD. I'm just throwing out a couple. 2C9, Depakote, right? 2C19, Lexapro, sertraline, escitalopram. All right.
Do we need to test these enzymes, or only if there's an issue with the medication not working on the patient?
It depends. So the way everyone's free to practice the way they do, but I don't really use genetic testing. I'm not a big believer in it, only because there's a lot of polymorphisms based on ethnicity. Like for instance, Asians, Southeast Asians to be specific, usually are 1A2 poor metabolizers. So if you give them a 1A2 medication, you have to be very sensitive to the dosing because they might have side effects. Like if you give them Haldol, they might have akathisia or dystonia, right? Just be aware that you might have to start slowly. And a lot of people are mixed. So sometimes it gets a little tricky with the testing, all right? But if someone comes to me and they've been on numerous medications, right, and we don't really know how to proceed because they've been on numerous meds and they have weird reactions to some meds, then yes, I'll do a panel and I'll check and it'll let me know. So I usually do GeneSight, but there's many other companies that do it, right? GeneSight is just the one that I'm familiar with, but there's many other companies. And they'll give you a breakdown of the enzymes. It'll break it down. It'll say, are they poor metabolizers, rapid metabolizers, intermediate metabolizer, which actually means regular, ultra rapid, which means they eat it up a lot faster. So there's ultra rapid, there's rapid, intermediate, right? Poor metabolizer. So there's different ways to break it down. Does that make sense?
Yeah, and are those expensive tests or?
They used to be, and not like $200. I mean, I guess it's depends on the patient, right? 200 might be expensive for some people, but might be okay for some. It depends. Yeah. And sometimes I think Medicare, Medicaid, it's covered. And sometimes some commercial plans have like coupons, so it really depends. So you can look it up for your patients. But it's good. It takes about 2 weeks for it to come back, and you can go over it with your patients. All right. Any questions? All right. Anatomy and physiology of the brain. All right. So you guys should have a general understanding about how the brain works. All right. So if I talk about the frontal lobe, what usually are we talking about? Person's ability to what? Yeah, judgment, right? Judgment is frontal lobe, right? So if someone is impulsive and they're making risky behaviors, what part of the brain do you think we would want to target with medication? Frontal lobe, right? If someone was psychotic, you would be targeting like the middle part of the brain, right? The mesolimbic pathway. I know you guys probably didn't get to that part. We're going to get to that when we talk about psychosis, but just general understanding, all right? So you have the association area, you have the frontal lobe, right? You have the parietal up here, right? In between the frontal lobe and the parietal, you have the sensory motor cortex, which is important. That has to do with movement, right? You have the temporal lobe over here, which is the auditory area, right? You have occipital, which is in the back, which you guys know has to do with like visual. Then you have the cerebellum, which has to do with balance. All right. Obviously, you have the brainstem, which has the cell body of a lot of our neurotransmitters. I want you guys to know the brainstem is important because the brainstem is where the ascending reticular activating system start, right? So it's a bunch of projections of the neurons that innervate your cortex, right? The cortex is your frontal cortex, parietal cortex, temporal cortex, and that ascending reticular activating system has to do with arousal, right? And salience. Anyone know what salience means? What does salience mean? Salience. Something that's important, right? So salience is like things that you find, appealing. So sometimes people who have schizophrenia, they have like a hypersalience, right? Their salience part of their brain is very active. So they might, I don't know, look out the window one morning and they see a black Lincoln Town car. And all of a sudden like, whoa, maybe it's because I was late with my taxes last year, right? Now that goes to the FBI's after me. And then they make this narrative because things are very salient to them, right? Little things that might just be coincidence, they start putting a story together, right? That's a hypothesis. There are many different hypotheses about what causes psychosis, schizophrenia, right? But one of the hypotheses is that it's a hypersalient state. So people put salience to things that there really is no meaning to it, right? They put meaning to things that's not there. Or they might have issues with perception too, right? Sometimes we can tell if it's a shadow of like, a mouse that's running through your house, right? You think it's something else. But they might make a whole story. Oh no, it's a demon, or it can really just blow up. All right, so hypersalient state. What if someone who has no salience? That could be depression, right? Nothing, anhedonia, nothing makes them happy. They have no drive, no motivation to do anything, right? So their salient system is broken, going to the other end. So you have to give them medication that might increase dopamine, right? If someone is psychotic or manic, you want to block dopamine because there might be hypersalience, right? They're putting meaning to things. Now, if someone is depressed and they don't feel pleasure and they can't put meaning to anything, maybe you want to increase dopamine. Does that make? I'm simplifying it, but it's giving you a general idea of how psychopharmacology works. Does that make sense? All right. Neurotransmitters. What are the monoamines? Give me an example of the monoamines. What are they?
Serotonin.
Okay, that's one. What's another monoamine?
Dopamine.
Very good. Dopamine. What's another monoamine?
North.
Norepinephrine.
Very good. All right. So if we give someone monoamine oxidase inhibitor, right? Monoamine oxidase breaks it down, right? For depressions, because I want to increase the amount of dopamine, norepinephrine, and serotonin in the brain. Does that make sense? So I'm stopping the enzyme that's breaking it down. So I'm increasing all three monoamines, right? Serotonin, dopamine, norepinephrine. The good thing about that is it's going to give someone relief of multiple symptoms, right? Because you're increasing everything. The downside to that is it's a messy drug, right? Because you're affecting so many different neurotransmitters that increased serotonin can cause what? Affective blending, sexual dysfunction, sometimes weight gain, sometimes insomnia, right? So it can cause a lot of other side effects. So sometimes you want to be maybe in the beginning, try to be very precise with your dosing with medications or your targeting with medications. And if one route of medication doesn't work, then you can start adding medication. Does that make sense? We're going to go into detail when we talk about the classes, but just a general idea now. All right. So once again, know the enzymes that break down the medication: 2D6, 3A4, 2C9, 2C19, 1A2, and 2B6 is important too, because 2B6 has to do with methadone, right? When you talk about substance abuse, you're gonna have to understand what 2B6 does. And also Wellbutrin. Wellbutrin is also broken down by 2B6. 2B is in boy, 6, right? Not 2D6. D is in dog. All right. I've been doing a lot of talking. So I'm going to open up the floor up a little bit so you guys can ask me any questions that you have about what you read so far. I mean, it's a big subject, so I don't want to recite everything you guys already read about. Anything that's not clear, anything you need me to explain?
I have a question.
Yes.
I know like in the other videos, like just like in general, when you were saying if someone was having side effects from a medication, a lot of times you would either possibly lower the dose or like change the medicine.
Yes.
But like is that just like a matter of choice? Or I mean, I would feel like almost probably trying to lower the dose of the same medicine they were on first before you change it up, or is it situational?
Well, the main issue is it depends on what the patient wants to do, right? So I present both ways, but there's risks and benefits to both ways. So if a patient has a partial response to the medication, right, but then I raise it, then they have side effects, then what I'll probably do is bring it back down to where it was before, where it wasn't giving side effects, but giving a partial response. Then I would add a medication, which is called augmentation, right, or combination. Does that make sense? If
Yeah.
you raise and if there's no effect and there's no, there's no benefit to it and there's side effects, I would just stop it and go to something else.
Okay.
Right? Sometimes it could be an effect, and then the patient goes to a side effect, and the patient goes, you know what, I don't want to be in two medications. Then obviously if the patient wants to do that, then you have no options but to switch them to another class, right? But I'll tell the patient the risk to that is we're kind of starting over again. So you're not going to build off those gains. If someone has partial improvement in their energy now with the SSRI, right? But they want to stop it because they're having sexual side effects in the medication going up in dose. We can switch you to Wellbutrin, but then we're going to have to maybe taper you off the SSRI if you really want to stop it, and then start the Wellbutrin because they don't want to be in two meds at the same time, right? Sometimes you can do something called cross titration, which you're dropping the first med and you're increasing the second med, right? The advantage of that is you're kind of not wasting time with washing out the other med. You can start already while one's dropping, the other one's going up. The downside to that is the patient has to take two medications. Some of them don't want to do that. The inconvenience about that. Does that make sense?
Yeah, no, it does. Thank you.
Any other questions?
Are we sticking to pharmacokinetics and pharmacodynamics right now?
You can ask me anything.
Okay. So let me just try to explain to you like autoreceptor. You tell me if I have the right idea in my head. So the autoreceptor is on the presynaptic neuron. So like the 5-HT2C receptor, right? When we give an antagonist for that, is that antagonizing the autoreceptor, which is stopping the disinhibition of serotonin, which increases the serotonin?
Yep, part of it right, part of it wrong. All right, let
Okay.
me correct this to everyone. So an autoreceptor is correct. You said that. It isn't on the presynaptic neuron. It's a shutoff valve. So it's a negative feedback loop, right? It's the way for your brain to actually shut off overstimulation, because overstimulation can cause something called excitotoxicity, right? Too much stimulation of a neuron is going to cause it to wither away and possibly die from the excitotoxicity, right? Which is why prolonged seizures sometimes can cause cell damage, right? Nonstop stimulation is going to cause cell damage. There has to be a shutoff valve. So one of the there's many autoreceptors, but 5-HT1A to make it simple, right? We're going to talk about that next week. 5-HT1A in a serotonin neuron is an autoreceptor. So what happens is after a while, when your presynaptic neuron is releasing serotonin, right? When it starts flooding that second postsynaptic neuron, eventually some of it's going to flow backwards, right? And it's going to touch that 5-HT1A autoreceptor. That's when it knows that there's too much. And then it's going to shut off. All right, 5-HT1A. Now, what happens over time is when you give someone a medication that floods that area, there's something called downregulation, which you talked about last week, which we're actually going to review now. Perfect segue. Downregulation and desensitization, right? So another way that a postsynaptic neuron protects itself is that if you flood it with too much stimulation of a neurotransmitter, it's going to downregulate, which means it's going to remove receptors and it's going to desensitize, which means that receptors are not going to be as sensitive, right? To help prevent from excitotoxicity, which I said, right? So what's going to happen is if you give someone an SSRI, for instance, right, in the presynaptic neuron, visualize that. You're stopping the reuptake pump, so all that serotonin is going to be free to stay in the synapse, right? Eventually, some of that serotonin is going to move to the autoreceptors, right? And once it keeps hitting that 5-HT1A autoreceptor, the 5-HT1A autoreceptor, if it keeps getting innervated with the serotonin that stays there, that's excess, it's going to start down-regulating and becoming desensitized. So therefore, it turns off, which is why sometimes it takes 2 to 4 weeks for the medications to work, because initially, you give someone an SSRI, it's actually going to reduce the amount of serotonin release, believe it or not, initially. Because you're going to increase serotonin, the serotonin is going to hit that 5-HT1A autoreceptor, it's going to shut it off. That's why there's no effect, and there could be side effects in the beginning. Over time, that serotonin is going to keep hitting that autoreceptor, and then it's going to desensitize and downregulate. It's going to shut it off. You're going to have no brakes, cutting the brakes to a car, right? So all it's going to do now is accelerate. Does that make sense? Evan, did I explain it to you? Do you understand?
Yeah, I think I'm just confused about you see some of the meds that are like
yeah, 5-HT2C is on a GABA interneuron. We're going to talk about that in detail when we talk about antidepressant. It's on a GABA.
The so book's saying like they're an antagonist, right?
Yes.
So if it's antagonizing that, but that's a serotonin receptor. I think in my mind, I'm like, oh, well, it's shutting off serotonin, but it's actually used for depression. So I was just confused about that.
When you look at the book, because the autoreceptors could be different. There's something called hetero. Hetero means that. So for instance, imagine you have a serotonin receptor, right? It doesn't just have serotonin receptors on there. There's also norepinephrine receptors on there also, which is called a heteroreceptor. It's another neurotransmitter that can bind to it, but it's on a separate neurotransmitter. Get it? So it's a serotonin neuron, because when it spits out a neurotransmitter, it's going to be serotonin, right? But the receptors on it, it also can have a receptor for norepinephrine, which is why we give some meds like mirtazapine, which is an alpha-2 antagonist, and it increases serotonin because it actually blocks the autoreceptor of shutting down the serotonin neuron. It all makes sense when we get to depression, all right? But you're on the right, you kind of have the right logic, but just know that the reason why it's complicated, because a lot of the neurons have different receptors on there. They're not just like a dopamine receptor has a serotonin receptor on there too. A dopamine neuron has serotonin receptors on there too. Right? Serotonin receptor can have norepinephrine receptors on there too. And it depends on what part of the brain it's located in.
Okay, so just because it's saying it's one of the serotonin receptor antagonists doesn't mean it's affecting solely serotonin.
Yes. It could be a serotonin receptor on a dopamine neuron, or it could be a serotonin receptor on a norepinephrine neuron. Right? It depends. Yeah. Listen, that's why we get paid the big bucks. So you got to know all this stuff. It's not easy. It's not that simple. All right. But it's good. You're starting building. You're building from it. But it gets complicated. That's why you can't. Don't think of like serotonin antagonists and you can't use it for depression, right? It's not reducing the amount of serotonin. It could be blocking an autoreceptor on a serotonin neuron. It's actually increasing that serotonin. All right. But good logic, good questions. This is what I want. I want you guys to think it through and visualize it, and I correct it, and we keep talking about it. All right. That's how you learn. Any other questions? That's why when you look at medications, like in the style book, there could be like six different mechanisms, right? It's a dopamine antagonist, 5-HT2A antagonist, 5-HT1A partial agonist, 5-HT3 antagonist, all right? 5-HT2C antagonist. Right? That's usually atypical antipsychotics I'm talking about, right? Give me a medication. Someone say a medication. It has to be psychiatric though. Just give me a medication. We're gonna play a game. Give me a medication that you saw today.
Lexapro?
Lexapro, right? It's an SSRI. That's easy. Serotonin reuptake inhibitor. That's really all that it does. Give me a complicated medication. Give me something else.
Clozapine.
Clozapine. Very good. All right. It's not a very strong D2 antagonist. It only blocks about 20 to 4% of D2, right? It's a very strong antihistamine, very strong anticholinergic medication. It's actually an inverse agonist to 5-HT2A, right? It's a 5-HT2C antagonist. All right. And it also modulates glutamate. Give me another medication. One more. I'm not showing off. I just want you guys to understand how I want you guys to be at when you finish.
Wellbutrin.
Huh?
Wellbutrin.
Wellbutrin, very good. Dopamine, norepinephrine reuptake inhibitor. That's an easy one. One more.
It works.
Marplan.
Which one?
Marplan.
Marplan. Oh, what's that one? That's an old one. What's the brand name?
I forget off the top of my head. It's an MAOI, I think. Yeah, it's an MAOI. Nardil, Marplan.
Isocarboxazid.
Hold on. Marplan. You got me, man. Nice. There you go. See, you get humbled sometime. Isocarboxazid, very good. Oh, it's pretty easy. It's a monoamine oxidase inhibitor. That was an easy one, but if I knew what the class was, I mean, it's the same mechanism. Yeah. All right. Very good. Point taken. I get it. Thank you. Thanks for keeping me honest. But there's a lot of meds. There's about 50, meds in psychiatry, which you think is a lot. It's actually not a lot. After a while, when you start prescribing them, you're going to start building a repertoire, right? Maybe in the beginning, when you're first practicing, you're comfortable with sertraline, you're comfortable with Wellbutrin. Maybe if someone comes with some psychosis, you'll use Abilify and risperidone. And then as you get comfortable with it, maybe for ADHD, you might maybe use Adderall in the beginning, and as you start building your repertoire, you start adding more and more meds, right? Because not everyone responds to the same medication. And you have to know the differences between them, right? You can't just give everybody sertraline. Because some people might have really bad GI side effects from it, all right? Other questions? This is a good one. A patient came to me and was depressed. So their primary care doctor put them on fluoxetine, right? Which is serotonin reuptake inhibitor. Very long half-life. Longest half-life of all the serotonin reuptake inhibitors, right? You were on it for about a month. Anxiety got a little bit better. Depression got a little bit better. But then all of a sudden they started sleeping. They stopped sleeping. I'm sorry. They stopped sleeping. Then they started talking a little bit fast. The primary care provider referred them to me because they couldn't handle it anymore. And they thought maybe it was bipolar disorder. We find out that there is a family history of bipolar disorder from the grandmother, right? Mother's side. So they don't want to stop the fluoxetine. It's bipolar 2 because they said it's helping with anxiety. So they want me to add something. So I add Abilify. About a week of being on Abilify 2, they start having side effects on Abilify. They're restless. They can't stay still. They're a little tired. Did I give them a med that caused a pharmacokinetic interaction or a med that caused a pharmacodynamic interaction?
Pharmacodynamic.
No, pharmacokinetic.
Kinetic.
Yeah. And why? Extra credit. What does fluoxetine do? It's a very strong inhibitor. It's an inhibitor of 2D6 and 3A4, right? Which usually metabolizes Abilify. So even though I give her 2 milligrams of Abilify, the Prozac is in the system, so she is going to have, not enough of the enzymes to break it down. So even though I give her 2 milligrams of Abilify, it might be like 10 milligrams or 5 milligrams, right? And she's having side effects of akathisia and sedation, right? Does that make sense? Because what might happen is the person, you might not understand that, and you might think that they're even more manic, right? Oh, she's pacing around, she feels anxious. Let me raise the Abilify to 5, and it's going to make it worse. Where the right thing to do actually should be to reduce it to maybe half, to 1 milligram. And then letting her know that there could be an interaction there. Or giving another medication that doesn't have that interaction, right? That's not going to increase the level. Because when a patient comes to you, it's going to be very complex if you don't understand these concepts. And they say, well, this doctor did this, and then they did that, and I had this side effect, and I don't know, I'm not really sure. And then you're trying to troubleshoot it, but then you're also giving meds that are going to make things worse. Right? But if you pick that up, you can say, well, the reason why you're doing this is maybe because the Abilify levels is too high. Maybe at the same time, they're poor metabolizers also, genetically. and you're giving them an inhibitor, and then their levels are like 10 times of what it is, if that makes sense.
So speaking of that, so say someone comes in, right, and they have bipolar, but they're presenting with depression. They have no family history of bipolar, but how do you know not to give an antidepressant to throw them into a manic
We're going
episode?
to talk about that. We're going to talk about that in detail. But actually, I'll touch on it a little bit. There's something called soft signs. All right. So it's not in DSM. Soft signs could be early age of onset, sudden severe symptoms at a younger age, maybe younger than 16. All right. Past trials of SSRIs, but they made you worse or didn't work at all. All right. Seasonality, does it happen mostly in the winter? Do you have a history of, maybe sub-threshold hypomania, risk-taking behaviors, engaging in, reckless sexual behaviors, but not enough to get that diagnosis, but, enough to make me suspicious about it. We call them soft signs. Soft signs.
So what would you do in that situation?
I wouldn't
What
give
would
them
you
SSRI.
prescribe?
I will put them on maybe lamotrigine, or maybe put an atypical antipsychotic based on the age and whatever, what other presenting stuff there is. Yeah.
Gotcha.
Yeah, one of my other jobs, I'm a consultant for a lot of primary care doctors, so they usually send patients to me after they failed in numerous SSRIs. And a lot of times it's actually because it's actually bipolar depression, which is missed. In a busy clinic, I get it, right? Primary care doctors are seeing patients back to back and they don't really have time. They give you a PHQ-9, right, which is for depression. If you score high on it, they give you an SSRI, right? But they don't have enough time to do more digging, asking about family history, asking about the soft signs, right? When did this occur? How severe was your depression, right? Was there a history of trauma? And then they put them on SSRIs. It's easy. And then all of a sudden, the person cycles or gets something called a mixed state, which they're depressed and they're hypomanic at the same time, right? Imagine being able not to sleep, but you're suicidal at the same time. So you're irritable, you're depressed, and you can't sleep. That's a recipe for disaster. That's a lot of times when people commit suicide, right? You put them in a mixed state. They have the best of both worlds. They don't feel good. Usually in mania, you think they're euphoric. They're not euphoric, right? They're still suicidal, and they have a lot of energy, and they can't sleep, and they want to sleep, right? Which is why sometimes there's that black box warning. I mean, it's debatable. People from both sides say maybe the box warning for SSRIs because people were bipolar and they were getting SSRIs and then put them in a mixed state and they were committing suicide. It's unclear what's happening, That's why they have the box warning now. If you prescribe an SSRI from 18 to 30, then you need to see them more frequently. You can't just give them an SSRI and say, see me in 2 months. You have to make sure you assess them for suicidal thinking. Check on them. I prescribe them an SSRI and I see them every week for that first month. If they have a therapist and they see every week already, then maybe I'll see them every 2 weeks. But if they don't have a therapist, then I definitely have to see them every week. And once I see them maybe having some subthreshold hypomania, I stop the SSRI or I add something on top right away. Never give an SSRI naked to someone who has bipolarity. We'll talk more detail about that, I think, next week when we talk about mood disorders. But yeah. Upregulation, downregulation, very important. Right? Those concepts are very important. Desensitization, resensitization. Know what an agonist does, stimulates a neuron. An antagonist blocks, but it's not going to block the constitutive activity, right? Constitutive is what Stahl talks about is what's needed just to keep the cell alive, right? So even if you give someone an antagonist, there's still going to be constitutive activity happening inside the cell, right? That's just normal functioning to keep the cell running, all right? If it has an agonist, then obviously there's going to be more, the messenger system is going to kick in. There's going to be more activity happening there, right? Only if you give someone an inverse agonist will it cut off. There's going to be no constitutive activity. All right, that's important. Antagonist.
Wouldn't the neuron die then?
It could, probably over time. Yeah, it could. But the good news, we don't have many inverse agonists in psychiatry. We don't really use many. There's only a few. Maybe 2. Right, agonist, know what partial agonist does, right? A partial agonist in the presence of a strong agonist is going to work as a net antagonist. So an example, if someone is using a lot of cocaine and you put them on Abilify, which is a D2 partial agonist, in theory, the Abilify should beat out the cocaine, and then it's going to block it so that they're not going to get the euphoric effect and not going to get the psychotic effect, right? But what happens is you can override affinity, so it has higher affinity, right? But you can always override affinity by volume. So for instance, if someone's using a lot of cocaine and they're using a lot of, like, they're loading up with cocaine, if you use enough cocaine, it'll actually override the partial agonist. So just be aware of that.
I have a question.
Yes.
If the antagonist does nothing, is there
Only,
a,
yes, an antagonist won't do anything unless there's an agonist present.
if there's no agonist present, it still does nothing, or
It's yeah, if there's no agonist present, it's kind of just doing constitutive activity.
okay, so do we use antagonist medications or there's none?
Of course we do. We use a lot of antagonist medications. We do. Dopamine blockers for schizophrenia, 5-HT2A antagonists for sexual side effects of psychiatric medications, right? A lot of antagonists, a lot. There's a lot. I would say maybe 90% of our medicines are antagonists, maybe only 10% agonists.
Okay, so if whatever problem they have is causing them to produce a lot of agonist, the antagonist would level it off.
Correct. Yes. Yes.
Okay.
In a general sense,
Oh.
yeah.
It will not cancel it, it will just put it to normal level.
Correct. Yeah, I'll bring it back to homeostasis. Yeah.
All right.
That's what we're trying to do. Yeah. So remember, none of our meds are cures, right? Last I checked, there was no cure for any mental health issue, right? Except one. There is one form of psychosis that you can cure. Anyone know what that is? Extra credit.
I'm gonna guess.
You engage in sexual behaviors, you don't wrap it up.
Mm.
You get something.
Neurosyphilis.
So yeah, very good. Syphilis, yeah. If you get it early enough and you give them penicillin G, right? You can cure the psychosis. Yeah.
What about postpartum?
Postpartum psychosis usually comes back. It doesn't
Doesn't go away?
usually it doesn't usually comes back. Yeah. I used to work in a perinatal clinic, so I know. Yeah. There are some patients that are in the clear, and for whatever reason it doesn't come back, but a lot of it does come back. Yeah. And sometimes that's linked to bipolarity also. If someone has postpartum psychosis, we usually treat them as if they have bipolar disorder.
Do you think it's something that they possibly had before and like the pregnancy, like
Yeah,
Right, yeah.
they're usually the genetically loaded. Genetic loading means that there's a family history. Yeah.
What about substance caused psychosis?
Well, I mean, as long as they can stop the substance use, yeah. But a lot of times it's relapse. Right? Addiction is, as we know, as our understanding of it now, it's an illness, right? That usually people relapse. So if they use again, it'll probably come back.
I have one question. One of my friends is a social worker, and we've been talking a lot lately about women who were presenting really with more anxiety or depression from trauma, and then to find out later it was undiagnosed ADHD. Have you seen that at all recently? I feel like maybe I'm just more used to it because I'm
I've seen
older.
everything.
Well, like I just more recently though, I feel like it's something I've been around recently where I've heard more people talking about it.
Well, when it comes to comorbidities, anxiety is one of the highest comorbidities of ADHD.
Yeah.
Which is why sometimes, it also can be a protective factor. And, people who believe in, what is that called? Darwinism, right? Survival of the fittest. Why are some genes carried over? Maybe if someone has ADHD and they didn't have anxiety, they would die quicker, right? Because think about it. If you're speeding on the highway and you have ADHD, you're impulsive. You're not really going to think about what your actions are going to do. But if you have a little bit of anxiety, you're going to say, well, maybe if I go too fast, I might crash my car, I might kill somebody. It's a protective factor.
Mhm.
A lot of times and the problem is you have to treat both. You can't treat one without the other usually. So a lot of times you will see people with ADHD and it might be a low dose SSRI, right? Or high dose SSRI. Yeah. There's a lot of comorbidities in psychiatry, so it's not one or the other. So a lot of times you're going to be ruling out, and a lot of it is going to be called. Are you guys taking the diagnosis class with Professor Smith? You guys? So he'll probably talk about that. Diagnosis of exclusion, right? You don't want to diagnose someone with schizophrenia right away. They come psychotic into your office. Is it substance induced, right? Is it amphetamine induced psychosis? Is it withdrawal from alcohol psychosis? Is it a brain tumor? Is it due to heavy metal poisoning? Is it due to, I don't know, many things, right? Bipolar could be people could be psychotic. Is it a personality disorder? So you want to rule things out first. Do a urine drug screen, do a brain scan, try to rule out heavy metal poisoning by doing heavy metal testing. Things that might look like it, right? Check copper levels. And if it's not that, then of course, then you would diagnose them. But I don't believe in people getting diagnosed with schizophrenia. Again, I was treating schizophrenia, for the past 5 years before I was here, before I was doing this now. So I was seeing a lot of patients that had a diagnosis, but I actually undiagnosed them. They didn't have schizophrenia. They were hospitalized once. They were held in the hospital for a week, and they were diagnosed with schizophrenia. I don't agree with that. I mean, they didn't really have the full symptoms. They didn't have a lot of the cognitive issues or the negative symptoms. We could talk about that later on about how, based on your ethnicity, how sometimes some diagnoses are carried over. Like if you're a person of color, right, you can probably get a diagnosis of schizophrenia more than a bipolar disorder. And you're probably gonna get put on a stronger antipsychotic more than anything else. And you're actually at risk of developing tardive dyskinesia if you get EPS right away. But we can talk about that later on. We'll talk about that when we talk about schizophrenia, right? Perception, right? Bias is very important. You check your bias at the door. Any other questions?
Yeah, so for the signal transduction cascade, so we should just really know that it takes time for things to start kicking in, or what should we know about that? Because it was very in depth in the reading.
It is. What's a fourth messenger? I'm just
Say that
kidding.
again.
I'm kidding. I'm not. I'm just kidding. No, just know the general idea about it. But do know what I do want you guys to know though is about epigenetics. Know about that concept. That's very important. Epigenetics. All right. Epigenetics means that genes could be turned on and off based on external stimuli or genetics, right? So for instance, someone can have genetic loaded, which means that their mom and dad both can have schizophrenia, right? And I'm just going to give a general percentage, give or take based on the study, it's about 10%, right? If both your mom and your dad have schizophrenia and they have an offspring, the chance of that offspring getting schizophrenia around, give or take, is 1 out of 10, right? 10%. If that offspring is a twin and their twin has schizophrenia and their biological twin, the chance of that other twin having schizophrenia is about 50 or 60%. That's the highest risk. All right. So even both parents have schizophrenia, the risk is about 1 in 10. All right. Now, the person who doesn't have the symptoms, let's say for instance, they have an offspring, right? They don't have the symptoms, right? There's a 10% chance that an offspring developing schizophrenia. They have the genes for schizophrenia, but if they're active, they have a pretty low stress job. They have parents that are supportive. They're very strict on them. They were very understanding. They showed very low expressed emotion, right? Sometimes you call that. So high expressed emotion can sometimes trigger people with psychosis. High expressed emotion means that when you see them, you say like, what's wrong with you? Or you get angry very quickly. You're expressing your emotion very quickly with them, right? High emotion. So that could be a risk factor, but maybe the parents show low expressed emotion to the kid, right? And the kid doesn't use marijuana. There's a chance that they might not have any symptoms at all, right? But then, they're exposed to poverty. The parents are very, neglectful of them. They start smoking marijuana at a young age. Then, of course, the risk of developing it. Because what happens is those genes are going to awaken based on early age marijuana use, right? Or adverse childhood experiences. They were molested, right? So that's how epigenetics can play a role in it. And you do that with your patients. Sometimes when you do counseling, right, with your patients. So your patients might come to you and say, hey, I know I have schizophrenia. I don't think anyone in my wife has it. What do you think my chances are of my kid having it? Right? And then you go through it and you talk about the risk factors. You can talk about, genetic loading. You can talk about what symptoms they might see, ways to kind of reduce the risk, right? But you have to understand all these concepts if you want to do that route. All right. Any questions? So does that make sense? Epigenetics. So genes can be silenced or they can be expressed, right? Methylation, deacetylation, right? Those are the concepts about it. Any questions? If there's no activity at a postsynaptic neuron and I give someone a partial agonist, is it going to work as a net agonist or a net antagonist?
Net agonist.
Net agonist, right? Because there's no neurotransmitter that's working there, right? What is synaptic plasticity? What does that mean? Synaptic plasticity. Sharon.
I actually do remember reading something about it. Does it have to do with like the reuptake?
It could, yeah. But in general, though, what does it mean? It means that your neurons can what? They can change connections, right? That's what synaptoplasticity means. That means that your brain can rewire and change in different ways, all right? That concept is important when it comes to trauma. Like say for instance, someone had a traumatic reaction to something, right? So what you're going to do is you're going to do some trauma processing and you're going to help build different connections so that when they see a dog, they're not going to freak out because they're not going to be reminded by when they were 5 years old that the dog bit their leg, right? So it's that concept that you're able to actually rewire the brain, quote unquote, and help them recover from that, right? That's really what processing is doing. That's what psychotherapy does. And that's what medication does also.
Is that like EMDR?
EMDR does that also, yes. Yeah, EMDR does. Do you know what EMDR does? Do you know have a general idea of how it works in the brain?
I've actually done EMDR. Yeah, it's pretty amazing. It like kind of
Can you explain? I'm sorry, they did it to you or you did it?
I had it done. Yeah. So
Nice.
I was diagnosed with, I'll just share because what the hell? I was diagnosed with
Oh
PTSD.
yeah, Mia.
I don't mind. I don't actually
You
don't
know,
mind.
I don't want to record this though. This is your business.
No, so I won't go too personal, but I being in trauma, I had a trauma years ago, so I had PTSD and I did EMDR. So what we did was it was virtual. So
Okay.
usually what they'll do is either you can follow like a dot across the screen, or you can do tapping
Okay.
like this. And it's supposed to, I really don't know how to describe it. You probably could better. It just kind of flips your brain because you're going back and forth and you go back to the initial memory that brought on the trauma and you kind of work yourself through it. So if your reaction was a 10, the goal is to kind of get down to like a 0.
How many treatments did it take for you to notice a difference?
5.
5. Excellent. That's actually that's a very big effect size, right? We'll
Yeah,
talk
I
about
was
that.
really ready for it and I kind of knew a lot about it and I was in therapy for a while, but it was pretty incredible. It's probably one of the most amazing experience I've ever had. I completely recommend it.
Supposedly the story was, I'm probably like, I'm paraphrasing it now, but
Yeah.
the person who invented it apparently was like walking in the garden and then they were
Mhm.
like looking left and right and they were thinking about their trauma and apparently it got better. Did you hear about that story?
I did hear that, yeah.
Which is pretty amazing, right? I mean, I don't know.
Yeah.
Okay, so how it works is that when you get traumatized, you're not really processing the full trauma, right? I'll use the dog biting example, right? Let's say you were 5 years old and a dog barked at you and bit you in the leg, right? Sometimes only one part of your brain is going to process that, right? So you have your left hemisphere, you have your right hemisphere, and that's linked through what? What's that middle part of your brain that connects them both together? The white area. What is it called? The CC. What is the CC? The corpus callosum, right? So you have the corpus callosum, which is connecting the left hemisphere and the right hemisphere, right? And what happens is, if you're processing only on one side, you can't really make sense of that. So for instance, you freaked out, and the fact that you weren't able to process it, you couldn't put a word to that feeling, for instance, right? I'll keep it very general. Like instead of telling someone, hey, that dog, that scared me, I'm petrified of dogs, you couldn't put that into words. So therefore, it's manifesting as high anxiety when you see dogs or anything that reminds you of that trauma, you start becoming agitated, right? You get very depressed and you're not really sure why because you weren't able to process it, right? So what happens is you kind of relive it again. You do narrative therapy. I'm not sure if they did that with you, but you go through the narrative again, making you feel safe with the therapist. And while you're kind of talking about it, it's almost like you're reliving it and you're doing the tapping because when you tap left, you're innervating the right side. Remember, our brain is contralateral, right? If you move your right side, it's innervating your left side. If you move your left side, it's innervating your right side, right? If you look left, you're innervating your right side of your brain. If you look right, you're innervating the left side of your brain, right? Because it's contralateral. So when you're doing your narrative and you're talking about your trauma and you're looking left and right or you're tapping left and right, you're activating both sides of your brain. So you're actually reliving your trauma in a safe space, but you're processing it together now. It's not just jointed. Does that make sense? That's a very general explanation, but and what we usually do as psychopharmacologists is you might put someone on maybe an SSRI to help calm down their amygdala because their amygdala is going to be hyperfiring from the emotion, and maybe a low dose Zoloft while they're doing trauma processing might help them tolerate it, right? Because they're going to remember, they're going to escalate because your body's going to, your locus ceruleus, right? So it's creating norepinephrine in your brainstem, and it's going to secrete all that, and you're going to go into a fight or flight response, right? Which is going to trigger your amygdala, it's going to cause even more norepinephrine release. So by giving someone an SSRI, you're going to, and a norepinephrine reuptake inhibitor, right? You're going to downregulate these norepinephrine receptors, and it's going to cause the reaction to be much less, right? And together with linking it with the left and right tapping or the eye movement is going to make that, make that new connection and make you process it so it doesn't feel like, that you're reliving it every time you see it, whatever your traumatic response is, right? Does that make sense? But EMDR is a great therapy for trauma, Exposure therapy also we use, ERP.
Is that like with ketamine too? It's like something I remember reading something about the memories, like it restores the memories.
Yeah, neurogenesis. Ketamine helps with forming of new connections. Yeah, and sometimes it can happen within a day to 3 days, which is the critical period. Which is why usually when people do ketamine treatments, we have them journal, they have intentions, right? Set and setting is important. What is their mindset, and what is the setting that they're in, right? Is it in the clinic, calm, calm music? Are they meditating? And then they're going to work on specific things, all right, during those next, 2 or 3 days after the ketamine treatment while the brain is plastic, right? Because the brain is going to release something called, so you read in the style book, they have those nerve growth factors, NGF, right? Which has to do with what? Is it anterograde neurotransmission or is it retrograde neurotransmission?
They're retrograde.
Retrograde?
Very good. Retrograde. It goes backwards, right? So nitric oxide, cannabinoid receptors, right? Nerve growth factors, those are retrograde. They go back. So the postsynaptic neuron actually feeds back to the presynaptic, right? So nitric oxide, nerve growth factors, cannabinoid receptors, those are all retrograde. So retro is going back, and antero is classical, goes after, right? I'm going to stop recording for the last 15 minutes so that we can talk about other stuff.